Hello and welcome to our latest Gastro Learning Live event. Gives me massive pleasure to welcome Professor Thomas-Gibson, who is a star of UK gastroenterology, Professor of Medicine at Imperial College and former Dean at St Mark's, former head of JAG, and as well as that, a fantastic teacher and a great colonoscopist. So we could hardly have anybody better to take us forward to discuss all we want to know about the polyps that we see in everyday clinical practice, and with a particular focus on endoscopic mucosal resection. Shuan, absolutely great to have you with us. We've only got half an hour. We've got a lot to cover. I just want to give you a scenario to see where we go from here. So 81-year-old patient with a known 3-centimeter polyp in the ascending colon. Now you're going to tell us all about this polyp and what we should be doing about it. But I wonder if we could just start by you telling us about issues other than the polyp, patient-related factors, and how we should be considering them as part of the overall polyp management. So great to have you with us, and I'm delighted to hear what you've got to tell us.
Thanks, George. You're far too generous with your introduction. It's lovely to be here this evening. This is such a common scenario. Obviously, this slide was produced ahead of tonight, but actually this faced me just really today, and faces us quite frequently. And the issue with this case is two primary things. One, it's a big polyp, and two, it's in an octogenarian. Endoscopists are definitely not ageist. However, there are often issues that you need to take into consideration. Not least, this 81-year-old has clearly cleared his bowel, and so actually he's already overcome the first hurdle. But even that can be onerous for some patients. If they've got neurological conditions, as I said, my patient today did, or cognitive difficulties, consent is going to be an issue, existing frailty is going to be an issue. That every patient, I don't know about UCH, but most patients seem to be on an anticoagulant or an antiplatelet agent these days. So, I always say, just because it can be removed doesn't mean it should be removed. And on the surface of it, I would say that this looks pretty benign. So there would be an argument possibly that you might not have to do anything with this polyp. So all of that has to be considered and discussed. And ideally, not when you've got the scope in. So this scenario, I would hope the endoscopist knew about this polyp before they got there. There's a clue. I don't know if you can see the clue on this image as to how they knew that there was going to be something they had to deal with. What, can you see the clue?
The fact that there's a cap on the end of the colonoscope?
Yeah, absolutely. So most of us you routinely scope with a transparent cap, but if you know that there's a flat lesion that you might have to resect for all sorts of reasons we might have time to touch on, having a transparent cap can help. And so I think this endoscopist knew that they were going to be probably resecting a lesion, and that's a good thing to do if you think you're going to have a flat lesion to resect.
Okay, and we're going to. This is quite a sizable lesion, and we're going to come on to that. You mentioned about patient factors. What about the other end of the spectrum? There's concern for whatever reason raised about a possible malignancy in a patient of this age, and you do the colonoscopy, and in fact, in the right colon, you find 2-millimeter lesions, and the patient is on perhaps an anticoagulant. Are there scenarios in which you say, okay, well, I'm not even going to remove this lesion? And what's your thought process in that? Is your view that, well, if they're fit enough to have PrEP and to have a colonoscopy, then any lesion, however small, is justified in terms of resection?
So that's another really good testing question that, again, many people ask and will come across. We have got some emerging evidence that removing small polyps on a single antiplatelet or anticoagulant agent is safe. But back to what I was just saying, just because you can do it doesn't mean that you should do it. So if you have somebody in their 80s who's particularly got a suspicious history, perhaps they're anemic, I would be thinking, well, certainly this polyp isn't responsible for their anemia, and you may be better off spending time looking carefully to make sure you haven't missed the angiodysplasia or indeed the flat, cecal cancer behind the ileocecal valve. And I wouldn't focus on removing diminutive polyps in that scenario. So an 80-year-old on an anticoagulant. But
okay.
If you, I think probably enough.
No, that's very helpful. And I think a point that you've consistently raised is that polyp management is a lot more than what's going on at the end of your colonoscope. But let's get back to what's going on at the end of the colonoscope. Tell us about how we should be assessing this lesion and as a prelude to resecting.
Okay, so I think many people that see a polyp like that would say it's large. I don't know what large is. It's a variable. It's a variable and imprecise word, and it's relatively flat. But that's often as much as you'll get on a referral. There's a large flat polyp, but of course that could be a very flat, sessile serrated polyp that you can remove even 3 or 4 centimeters with cold snare very safely. Or a large polyp could be a 3 centimeter golf ball, which is much more risky and much higher risk of invasion and needs a completely different consent and approach to how you're going to do it. So just using words like large or flat is not enough. And so we try and classify polyps, and there are a number of ways of classifying them. So I don't know, have you heard of please say yes, have you heard of the SMSA classification for polyps?
SMSA, is that like MDMA, or is that that's something else? Do you know?
I'll give you a clue. The S is size.
So I think, don't get me onto detail, but I think size, morphology, site, and access. In other words, how overall difficulty. But
so we developed a scoring system some years ago, and it's subsequently been validated. And it was actually through work following on from the DOPIS work and in the bowel cancer screening program, because it was clear that some guidance needs to be given both for deciding if you could remove a polyp at an index colonoscopy or whether you should rebook it, and indeed whether you should refer it on. And this group of authors met and talked about the different parameters that would cause a range of difficulty in a polyp, because we know that actually you can have quite a small polyp, but say 1 centimeter, but if it's overlying the appendix orifice, or it's in a diverticular segment, or it's behind a fold, it could be difficult. So size alone is not enough to describe the level of difficulty. So you can see here that we can describe a polyp of being, either less than 1 centimeter or moving through greater than 4 centimeters, and it's attributed a score. We know generally that a pedunculated polyp is more straightforward to remove in general. A sessile polyp is a bit more difficult, often needs a lift, and a flat polyp can be very challenging. So the scores go up. Site, really the only evidence for difficulty with site is whether it's in the left or right colon, and that's very broad, but it's generally accepted that right colon is more technically difficult, usually because of things like or sometimes worse bowel preparation. In the cecum, the wall is definitely thinner, and sometimes positioning can be difficult around the hepatic flexure. And access, we just split. We couldn't really agree on the detail there, so we just agreed on easy or difficult. And difficult might include around the appendiceal orifice, around the ileocecal valve, associated with diverticulosis at the dentate line, or it could just be one of those really difficult to access polyps that's stuck down or behind a fold anywhere. So you can, I think the next slide shows you can add up these scores and it will give you a level of polypectomy. So a level 1 polypectomy will have a low score, and a level 4 polypectomy will have a much higher score. And you can see Mike Burke's group here, the paper in endoscopy that's shown there. They have validated this such that the higher the score, so level 4 polyps are associated with increased incidence of complication, bleeding and perforation, increased incidence of failed EMR, and increased incidence of recurrence. So that allows you to not only consent your patient, but also to decide who in the department is going to be able to remove those lesions.
That's incredibly, clinically just incredibly useful. Just briefly, and we touched on this, or we discussed this with a former Gastro Learning Live meeting we did with John Anderson. And in fact, for those on the webinar tonight, you might want to refer back to his discussion about polyp classification, which even with his clear guidance, I find a challenge. How do you apply, before we move on to resection, Kudo, Paris, to an ignorant HPB endoscopists? This SMSA classification looks easier to access and apply than the otherwise very good Kudo, etc.
So you're right, and there are a plethora of classifications. So you mentioned the most common, but there's the NICE, there's the JNET, there's the, it's endless. What I usually say to trainees is get familiar with definitely Paris, because that describes the morphology, and one of the other ones. And it's difficult because there are different ones depending on what kit you use. So for example, the Kudo classification, strictly speaking, should be with magnifying endoscopy, and use of dark dyes such as methylene blue. But it is, as you can see here, it is really transferable to indigo carmine dye and narrowband imaging. But NICE relies on narrowband imaging, which is an Olympus specific tool. And so you kind of need to be familiar with what's available to you. The Paris classification, we haven't got that here, but that is, I kind of alluded to it earlier, that tells you whether a polyp is stalked or sessile or flat. And that will again give you some idea of both the difficulty, but also the likelihood, here we go, the likelihood of there being malignancy. So the flatter the lesion in general, and certainly if there are these depressed lesions at the bottom, you're much more likely to have advanced neoplasia in them. That's not to say that big pedunculated polyps can't have, they can do, and sessile polyps, but the risk of malignancy goes up, and you definitely need to be able to recognize 2C lesions which are excavated or depressed.
Okay.
So that's how the polyp looks. We've already talked about, and so that's the morphology bit in SMSA. Kudo looks at the pit pattern, and NICE, the equivalent of it, looks at the pit pattern, and again is associated to the histology. So the NICE 1 polyps are hyperplastic or serrated, NICE 2 are adenomas, and NICE 3 are cancers. And then there are sub-classifications of that, which I think, as you were saying, you can look at one of your previous episodes to have a look at that in detail.
That's great. There seems to me that over the last 10 or 15 years, there's been, an increased focus, excuse the pun, on the pit pattern and even the sort of microscopic appearances of the polyp. But is there an argument for, as we assess these polyps before we resect, as we're going to come on to, for essentially standing back and getting an overall view of the polyp rather than, or in addition to a detailed assessment of pit pattern, etc.?
Yeah, so I always talk about the bird's eye view, and that polyp that you showed us at the beginning, and it's a really important point that you've raised, because that's fine to give you an overview of the polyp. It gives you an idea of the size with perspective and the overall morphology, but you can have both different Paris classifications within one polyp. So you can have a flat bit and you can have a sessile bit, and you might describe that as a 1S plus 2A. So 1S being sessile component and 2A being a flat component. The relevance there is that the malignancy, if there is malignancy or high grade, is most likely to be under the sessile or the dominant nodule bit of it. So you can assess that from afar. But the Kudo or the pit pattern, the nice classification, again, you can have different types within a big polyp. So small polyps will usually just have one type of histology, but larger polyps can have one area with perhaps adenomatous pattern, nice 3L pits, nice and even and regular. We might have some pictures that we could show you, but another area that has type 3 or invasive pit pattern. And so the bird's eye view is not going to be good enough for that. So the message here is that when you look at a polyp like this, it's great to take that nice picture that we saw right at the beginning. The first thing to say is fantastic, it's clean. There's no, don't take a picture with stool all over the polyp, because even if you wash it off after you've taken the picture, the next endoscopist is going to say, well, you couldn't see what you were looking at. No wonder you were surprised there was malignancy. So wash it off, get up really close. If you've got near focus or the equivalent on your scope, then use it routinely. And you have to scrutinize the whole of a big lesion like that, because it may only be one area that's got a focus of advanced neoplasia or type 3, nice type 3 or Kudo type 5, whichever one you're using. And you can see here on the left-hand side, that image, I'm not so worried about. There's a bit of mucus over it, and it's a little bit, sorry if it's one of yours, George, but it's a little bit out of focus. But, there's some regularity. However, if this is the same lesion on the right, I'd be concerned because it's a nice close-up view and you lose that regularity of pits. There's an increased vascularity. And so I would be concerned that this was a malignancy or a malignant focus of that lesion.
Okay, great. Before we move on to resection, what about scope orientation? A lot of us are just happy to, find ourselves looking at a polyp and say, right, that's a polyp. Now what do we do? But for these larger lesions, is there a sort of process that you follow to, examine antegrade, retrograde, for example?
Yeah, so say you have, in anywhere in the colon, you want to be able to visualize the whole lesion. And actually the ones that often, again, a recent case that had been referred to me as a very benign lesion, unfortunately the image capture hadn't worked. That happens with all of us, and it was described as a large, bulky, but very benign villous looking polyp. Sounds like it could be resectable. But actually it wasn't lumen filling, but the downward view of the polyp, so the anal facing view of the polyp was very benign, nice villous architecture. I had the advantage of having a cap because we thought we were probably going to resect it. And that allowed me not even to retroflex, but to push the polyp back to one side. And it did have, unfortunately, a malignant focus on the back of it. So it reinforces the point that if you can't visualize the whole of the polyp, you're going to have to do something else. And that might be position change, which will often help you. And that might have to happen during resection. We'll talk about resection in a moment. But to assess a polyp, a large polyp, you may need to use position change, and that can make a dramatic difference. Or you may need to, if it's safe, retroflex. Within the ascending colon, that's very safe, or even down by the dentate line. And I would always encourage you to do that, because what's on one side of a polyp may be very different to what's on the other side of it.
Okay, great. Let's move on to resection. And you've mentioned that you may want to change scope position as part of resection. I suppose a first point is en bloc versus piecemeal. There is a macho culture about, if you're piecemeal, sometimes it seems to me is a dirty word.
So last season.
Yeah. Okay. So tell us what the position is on that.
Okay. Well, I'm mindful that we've got a question that I'll try and bring into this answer. So I think probably one of the most macho endoscopists we know is Mike Burke in Australia, as you know, and he actually is a strong advocate of EMR. So I think we're in a good camp, and I think there is still a place for EMR, particularly in the right colon and cecum, particularly in older people where, you know, they haven't got a lifetime of the concern about recurrence, especially where there is a very, very benign morphology and, you know, appearance, and outside of the rectum. So in general, if you have a large polyp, say the size of the polyp that we just saw, and it's in the rectum, then the current thinking is that that should, in many circumstances, be an en bloc resection. That polyp outside of the rectum in a younger person may also be suitable for an ESD or an en bloc resection. But of course, we don't have very many endoscopists who are skilled enough or who have time and capacity in their unit to do en bloc resections. They take longer. It's a much longer learning curve. But the general principle is, you know, what would happen if this patient has recurrence? Because EMR, although it's much better now, EMR is associated with a higher recurrence rate. But if they're younger and if it's in the rectum, you really want to get a definitive resection for larger lesions. Okay. One of our audience has asked about, should we lift oral polyps in order to see if they can be endoscopically resected? In general, I would say no, particularly if you're assessing it. However, if you think that it looks like it's stuck down or it may have a malignant focus and you're not confident with the classifications that I've just been talking about, actually, these days, I would say take really good quality bird's eye view picture and close-up images of a clean polyp in focus, and that is probably better than trying to lift. Most of our ESD and EMR colleagues would say that whereas saline alone probably doesn't interfere with the plane, it really is best to avoid interfering with a polyp unless you really need to, so biopsying and lifting, unless you're going to try and go on to resect it. And now I think imaging supersedes an assessment as to whether something is going to lift or not, with the exception of recurrence. Okay, great.
Can I ask about snares and use of snares? Again, it strikes me that diathermy is so last century. Everybody seems to be removing, you know, doing EMRs with cold snare. Tell us a bit about choice of snares and, you know, where there is still a role or otherwise for diathermy for piecemeal or en bloc EMR.
So again, there's a question from the audience. So the vast majority, so more than 90% of the polyps that we see are less than 2 centimeters in size. And many polyps, there's even emerging evidence now for larger adenomas to be removed by cold snare and by even piecemeal cold EMR. But if we stick to all polyps under 10 millimeters, first of all, once you've excluded advanced pathology, so you have to look at the polyp carefully, then under 10 millimeters, pretty much in every occasion, you should be thinking about cold snare. But do use a dedicated cold snare, and there are a number of them on the market. The diathermy snares do not cut through as well as the dedicated cold snares. So get used to a dedicated cold snare. Some of them rotate, and that is your best friend. You will use that for the vast majority of polyps that we see. Sessile serrated polyps without areas suspicious for dysplasia, even if they are 3 or 4 centimeters, can also be removed with cold snare by a piecemeal technique, usually with a bit of lift underneath them. And you just shave them off. You take a rim of normal mucosa and they just come off beautifully. If you've got a larger adenomatous lesion, so above 10 millimeters, then that usually needs diathermy. The evidence, as I say, there's one paper that I'm aware of that has shown, and I don't know whether the backroom staff can find this, but there's one paper recently that has shown that polyps up to about 15 millimeters, even if they're an adenoma, you can cold snare. But in general, once you get above 10 millimeters, the risk of bleeding goes up with cold snare, and actually you just can't cut through the tissue. So that's when you would think about using diathermy, not just to seal the blood vessels, but to physically cut through the tissue.
We'll certainly put we'll put that paper reference on the site, and if you could remember the first author before the end, that would be even better.
I hope it's not a UCH author. It's not.
What about closing defects and hemostasis? You know, are you, again, clips and, you know, hemostatic agents seem to be used much more freely, shall we say, than was true just a few years ago?
Yeah. So I'm going to put my green endoscopy hat on now. So sustainable endoscopy. And I'm probably over the years been too guilty of this, of using too many clips. There is not good evidence for clipping up EMR defects. There are problems with clipping up EMR defects in that if there is any recurrence, it can be difficult to identify. It can potentially be buried in the closed defect. If you've got two edges and you bring them together, if there's a bit of adenoma on the tips and you clip it together, it'll be buried in the defect. Secondly, you can get clip artifact very commonly, which is sort of little knobbly bits, and then that's difficult to tell whether or not you've got recurrence or not. And the risk of delayed bleeding isn't significantly reduced by clips, but there are some exceptions to that rule. And in patients who are, again, elderly and comorbid, or who have to go back on their anticoagulants and antiplatelets, or have got large right-sided lesions, I usually would treating the edges to try and make sure that there's no recurrence. But I will clip those because having a large right-sided bleed in a comorbid patient or a patient who lives far away from me is going to be risky. There we are. Thank you.
Very good.
And so here's one I prepared earlier. And so clips, yes, for right-sided lesions, I would consider in elderly comorbid, those who live far away, those who are going back onto antiplatelets and anticoagulants. The other thing you can do, and there's emerging literature for, is things like Puristat. If there's active bleeding or active ooze, you can use Puristat, and there's emerging evidence for that. You have to remember that if you use adrenaline in your lifting solution, you can be falsely reassured. And so if for any reason, certainly if you see a vessel standing proud, or there's almost like hematoma in the base of your EMR, again, Brian Saunders and Zach Siamelos had a paper some years ago, I'm testing you now, Tarek, where they showed what the EMR defect how that predicts delayed bleeding, and having a hematoma in the base is one of the predictors for delayed bleeding. But otherwise, try and keep the clips available to hand, but don't use them too freely.
Okay, of course, we're not going to be able to cover everything. Question from Rosa Vega, who of course is very experienced interventional colonoscopist with us at UCH. Underwater EMR, is that going to remain in the hands of the specialist, or is it something that the colonoscopist should be looking to utilize for EMR?
It's an emerging technique, and some of my colleagues, probably Rosa, will do big lesions on block underwater. No lift. The principle is that you flood the colon segment with water. You don't use a lift, and you hot snare a lesion off. And that seems bonkers. So what I'm going to use hot snare in a sessile or flat lesion without any lift. But the idea is that the polyp is floating. And therefore it's floating away from the deeper wall, and it's safe. It is a really nice technique in a number of scenarios. We probably haven't got time to go into all of them, but recurrence is one. And there's no reason why anybody here can't try it. You can do it as a hybrid. So you can lift, and if you're starting the technique, just try it. You have to flood the bit of the colon, literally flood it without any air. You can always start by lifting the lesion as well, so hybrid, just to get a feel for it and confidence, or try it on smaller polyps. Gives you beautiful views because the view is magnified with the water. You can't have an air fluid interface though. It has to be completely flooded, and you have to have perfect prep. So there are some advantages to it, but start off small. I wouldn't do your first underwater EMR on a 3 centimetre sessile polyp. You might run into trouble.
Before we get on to really a final question about referral practice, just about a couple of words about tattooing. By definition, the lesions we've described here are large lesions. All of them should be tattooed, and if they should, where are you tattooing these lesions?
So not in the cecum, not in the rectum. You don't need to tattoo polyps there because anatomically, if you're sure, so if you've got a scope guide and you've seen the ileocecal valve and it's definitely in the cecum, you don't need to tattoo. The rectum, it's a pretty obvious where you are, hopefully, if you're in the rectum, but even if it's in the upper rectum, really talk to your surgeon and understand what they want, because they really do not like tattooing in the rectum because it ruins the planes for resection. And after all, we're usually tattooing either because we're concerned about malignancy or recurrence. So large polyps over 2 centimetres, we would usually think about tattooing. In the UK, the general guidance is that you tattoo on the anal side of the lesion, so distal to the lesion, and you place 3 tattoos. And we usually put saline in first to avoid the tattooing ink going into the peritoneal cavity.
Okay, fantastic. Right, last 30 seconds. Referrals. Now these large lesions, many colonoscopists are not going to, even after your fantastic teaching, are not going to look to take on these lesions themselves. Give us just a couple of bullet points about what you like to see in a good referral of a patient referred to St. Mark's or UCH or wherever for an advanced resection for EMR, for example.
So I want to know how, the fitness of the patient and their tolerance, and whether it's relevant to do it in that patient, their comorbidities. So maybe even a Charleston morbidity index or similar, and how they've tolerated the previous colonoscopy. Are they going to manage it under sedation? Do they need propofol? I need really high quality images. So the bird's eye view and then close-up images. I would like to know the SMSA score, the Kudo, the Paris classification, and the Kudo classification. And that, I think, even if you had that much information, that tells me that that endoscopist has been very thoughtful and has thought about this. And those would be the key things that I want to know. And of course, that the patient wants you to pursue it. So their comorbidity and their tolerance for colonoscopy. Obviously, if there's anything technically difficult about the procedure when they have their index colonoscopy, and then those things about the polyp with really high quality images. Fantastic.
Okay, listen, we've, goodness me, we could have talked for about 2 hours on this topic. Fantastic session, Shuan. Just for those who are interested, this session can be reviewed at any time on the GastroLearning site. And, I think just the ability to go back and remind ourselves about SMSA and the polyp classification will be incredibly clinically useful. So Shuan, as always, great to have you with us. Absolutely fantastic session. And thanks everybody for joining us this evening. All the best.
Thanks very much. Bye-bye.